Hi everyone, this is Counseling 2500, Chapter 11, Diagnosis and Treatment Planning. So the process and the product of diagnosis. So what this chapter really is about is, deciding whether or not you understand what kind of problem, mental illness, disease, disability that your client may have. Okay, and it's really important because this is the big part when it comes to paperwork. All right, so let's just talk a little bit about what the basic vocabulary words are. It's a really good intro. So what is a diagnosis? The act of identifying and naming the nature of a problem, and with the expectation that this naming will lead to a more informed and effective means of solving the problem. So what does that mean? That means figuring out what it is, and then so that you can actually then now understand how to help this person. Rely on the use of a common language to identify the presence of an agreed upon phenomenon, syndrome, or disorder. So when it says relies on the use of a common language, what that means is, let's say that there are 50 psychologists or counselors, right? And they all should be using the same words for the same things that they're observing from the client's behaviors, okay? Because what happens is if 50 counselors saw the same person and used different words to describe what's going on, then no one will really know what this person has, right? However, when you're properly trained to see a person in a specific way, then you're going to go, okay, well, this is how I see this person. And the other 49 should have something very similar, if not exact, to what you're saying. That way, it can also help to choose a plan of treatment. And then, of course, all of these agreed upon terminologies and language and all this other stuff is based on research and standards. Diagnosis should be clear, precise, depends on the perspective of the people. So that means basically talking to your client and finding out how they see the world, because the way that they see it might actually be fine and it kind of makes sense. And of course, the context of the experiences. And what that is saying is, being multiculturally competent. So that let's say that if you have a client that's very quiet, it doesn't necessarily mean that they're antisocial. It could actually be the way that they were brought up, and that's the reason why they're quiet. Okay. Diagnosis is based on client signs, client symptoms, structured or non-structured interviews, third-party information, in psychological tests. So let's just, I'm going to define signs and symptoms in a second, but I just want to let you know, structured or non-structured interviews basically means, is there, like, let's say if you're talking to someone, is there a form that you're going along with when you're asking those questions? So that would be very structured, right? An unstructured one might be just having a conversation with them, and then you're going to pick out what you need from that information to help you understand this person. Third-party information basically means, let's say, a friend, a parent, point of view, how they see the situation, and that would be third party. And then, of course, psychological tests basically means assessments. So signs. Signs are behaviors or characteristics that can be seen, heard, or detected by others. So this is stuff that anyone can see, and they would all agree on the same thing, which is like seeing someone pace. Pace is walking back and forth. Crying, rapid or incoherent speech, unkempt personal appearance and hygiene, and muteness. Muteness is basically nonverbal. That's the more correct way of using it now, or saying is nonverbal over muteness. But basically means that the person's not talking. So if everyone looks at one client and the client is crying, I think all of us would agree that the person is crying, right? So this is what it means when we're talking about signs, things that are observable. Symptoms can be seen, heard, or felt only by the person experiencing it. So when people ask for symptoms, they're asking, what are you feeling at this moment? So those are things that we personally cannot observe. So that might be anxiety, sadness, or even hallucinations. The Diagnostic and Statistical Manual of Mental Disorders is also known as the DSM. Most well-known and widely used system, and it was created in 1952. And as you can see in this image here, we've gone through 5 editions of it now. Okay, so the process of diagnosis is identify a client's experiences as belonging to a group or cluster based on similarities. Then determine important differences among the experiences of distress through assessments. And then assessment should include individual factors, family, cultural, and other contextual factors. Remember, contextual means within a specific situation or environment, right? So these are ways of how helping a person figure out the diagnosis. Okay. Okay, so let's talk a little bit about clustering client problems. So let's say the example would be anxiety. You want to differentiate them from various types of anxiety. So that means there are different types of anxiety, and we need to know what is the triggering event, how intense is the anxiety, or other factors that might happen when it comes to anxiety so that you can make a differential diagnosis. Obviously, anxiety is like a broad term, right? But when we go into diagnosis, we need to know more specifics. Is it something that happened in their past, or is it something that just doesn't exist, but they just feel the anxiety? What does that mean, right? And of course, then we would assign a formal diagnosis once we are able to narrow it down. If a client's signs and symptoms do not meet the criteria for a DSM diagnosis, this does not mean that the client doesn't need or won't benefit from counseling. So just because we can't maybe figure it out just yet when you talk to your client doesn't mean that counseling doesn't help, right? So you might want them to still continue or start doing counseling until we are able to figure out what's going on. Client will seek help with typical developmental needs such as career choice, relationship issues, adaptation to life changes, and challenges. So those are things that might be associated with anxiety. So you might go through those things with them, and then you'll be able to better understand the person and their anxiety. Okay. In this book, it references the DSM-5, which is the most recent. The first version is 2013. Let's define what mental disorder is, okay? Syndrome that impairs a person's ability to think, manage emotions, or behaviors that reflect a dysfunction in psychological, biological, or developmental processes, okay? So what a mental disorder is something that prevents a person from being able to think or manage their emotions, right, or behaviors, and so it becomes and being seen as very dysfunctional. Okay. Behaviors are expected responses to an event or a stressor. Behaviors that belong to a person's culture or religion, such as a grieving ritual, are not considered mental disorders. Okay, so what that is saying is there are some cultures where they will dig up the corpse of their families once every 5 years, and they're going to clean out the body, put on new clothes for the dead body. For a Westerner, or from other countries as well, they're like, whoa, that is like freaky. That is weird, right? But the thing is, if that's within their culture, then that would not be considered a mental illness, right? It is when things are not acceptable in all bunch of different cultures, when you start to think about it, whether or not it is actually a mental illness. One of these three things need to be present when it comes to a mental disorder. Number one, currently experiencing distress. 2, demonstrates impairment or a disability in daily functioning. And 3, is at a significantly increased risk of suffering death, pain, disability, or an important loss of freedom. So one of these three things need to be present for us to move forward, okay? And usually people are expressing a lot of distress, right, when they come in and see you. All right, so expanding the role of diagnosis and counseling. There's actually a lot of drama that comes along with counseling, psychiatrists, psychologists, and all that other fun stuff. Well, anyways, let's start off with Council on Accreditation of Counseling and Related Educational Programs, also known as CACREP. Requires certain accredited counselor education programs include coursework on the diagnosis, treatment, and prevention of mental disorders. And of course, the current one is called the DSM. So once you get into your master's program, you will realize that you will have to take a class just specifically on the DSM. And the reason why is because you need to be able to understand it, use the book, find things that you need to find immediately, and kind of understand the gist of what it's talking about. Because it's going to help with your paperwork, it's going to help with your treatment plan, and it's going to help with insurance purposes, which we'll talk about later on. Okay, so the reason why we expand the role of diagnosis and counseling. Development and use of a common diagnostic language enhances our ability to generate and share research and ideas both within the counseling profession and among the other mental health professions. So what that means is by doing research and stuff like that within the counseling education, it's going to add more and help everyone understand, let's say, disabilities, mental health even better. An accurate diagnosis is the foundation of appropriate treatment planning and using research-supported practices. So, I mean, that's kind of obvious, right? So if you are able to diagnose someone accurately, then the treatment plan that goes along with it will most likely also probably work. And the reason why is because a lot of people have done research on how to, let's say, help this specific type of mental health, then you're going to be more likely to succeed. Professional counselors are increasingly being recognized as primary providers of mental health care. Third-party payment insurance needs a formal diagnosis. So before, counselors didn't really do a lot of it, but they did. Okay, so but now because they have that DSM education, they definitely are doing it as a counselor. Okay, and then of course because payment, again, we talked about insurance and stuff like that, they need to know what's going on with the person that they're paying the insurance for. Professional counselors must recognize and practice within the boundaries of their scope of practice and their individual levels of experience, knowledge, and skill. Referrals and collaborations with others, such as a psychiatrist, for medication. So again, like we talked about in ethics, as a counselor, you should only practice within the area that you definitely understand, that you studied, that you experienced, that you know, right? So like, let's say, for example, if I didn't know anything about addictions, I probably would not necessarily have a client that is dealing with addictions. Okay, I would actually refer them to an addiction specialist because I want them to be able to help, right? But it doesn't mean that I can't help them per se, but we work along together and we'll explain it. But overall, if it is someone who has an addiction, I would probably refer them and I would explain to them very point blankly, there are these people who are very experienced with this. Would you like to go and work with them? Okay, but you're welcome to stay here as well, and we can work on it together as well. Potential benefits and risks of diagnosis to the client. So when you give a client a diagnosis, there's actually good things that could happen and bad things that could happen, or a little bit of both, right? So here are some benefits. Gives a name to the client's distress. So they finally know, oh my gosh, I have ADHD, right? And that might make them feel really good because I've been trying to figure out why I've been not doing so well, let's say in school or whatever, and now I know. Client is not alone in their misery. They don't feel alienated. And once they know, they can actually look it up and they can maybe even join chat rooms or support groups within that specific field or mental health issue. And then they're like, oh my gosh, there's other people just like me. I'm not alone. Family may be more understanding of the client's difficulties, so they could be supportive. When your family knows, like, oh, wait a minute, this person has, let's say, autism, then they might not necessarily get annoyed with that person. Let's say if they had frustrating experiences with them, they're like, oh, wait a minute, it's because this person has autism. Help the client engage with counseling, joining peer support groups, go to a psychologist for more testing, go to a psychiatrist for medication, and for insurance purposes, no diagnosis, no way to get treatment. All right, and now let's talk a little bit about the risks. Leads to a sense of hopelessness. For some people, it might become that, right? Feeling that the situation is outside the client's control. So they're going to say something like, well, I have this, so there's really no point in me doing anything because I'm going to mess it up anyways, right? Used as an excuse for irresponsible or destructive behaviors. So they're basically refusing to take responsibility, right? So let's say that let's say, let's just say ADHD, right? And so then they don't really focus on their homework, so they can't really score really well in their schooling. They're going to say, well, I can't help it. I have ADHD, so that's why I can't focus. I can't study, so therefore I'm going to fail anyway, so it doesn't really matter. So you're using it as an excuse as opposed to trying to figure out what are good ways for a person with ADHD to be able to study successfully. Stigma that comes along with psychiatric diagnosis by other people. So, when other people hear that you have, let's say, ADHD or something, they're going to go, oh, they might sound like they're pitying you. They're like, they don't want to be your friend or whatever. Sometimes people think that you can catch diseases. Obviously, some you can, but there are other things that you cannot catch, right? But people might have that stigma, like, I don't want to hang out with that person because, they might be a little weird, crazy, or whatever, even though it's true, not true. Okay. Known diagnoses may prevent getting insurance or employment. The person becomes a diagnosis, so instead of saying, I have bipolar disorder, they're going to say, I am bipolar disorder. So it lets them, lets the disease or the mental health take over their lives. Family may use it to blame the family's dysfunction. So maybe the parents have been very unhappy with each other, and then they're going to use their child's disability to blame the reason why their marriage is falling apart. Family may over-coddle or shelter the person and prevent independence. So for some parents, they're like, oh, well, my child has this, so they can't do anything, so I have to do everything. So that makes them very, very dependent on their parents because their parents won't let them actually do anything. Strengths and talents eclipsed by the disorder. Some diagnoses will lose focus on the cultural or systemic factors that cause a disorder. So an example would be depression, anger, anxiety are responses to sexual abuse, right? So sometimes we don't really get to see what the real problem was, which is sexual abuse. And this is the reason why people are depressed, not just because they're just depressed. So let's talk a little bit about the history and overview of the DSM. So what is the DSM? It's a compilation of all mental disorders recognized by the APA, or the American Psychological Association. Grouped according to shared characteristics, descriptions of the signs and symptoms that must be present, such as diagnostic criteria, or that's what it's also known as. Incidence of disorders, so that means like how often does it happen, how long does it happen for, and all that type of stuff. Usual age of onset, which is around what age did this person start to develop these, let's say, dysfunctional behaviors. Expected course of the disorder, so that means like it might start when they're 16, and what is it going to look like when they're 60, so that we understand the lifespan of this disease or disability along with this person as they get older. Issues that might interfere with the correct differential diagnosis. And then, of course, cultural considerations. So again, this is what the overall DSM is all about. The DSM is also based on the medical model, like a physician trying to identify and treat a pathology. A pathology is like an illness or a disease or something like that. So it does not focus on wellness. And so the example is you have a headache, the doctor will say, take some Tylenol, because they're not going to ask you if you've had enough sleep or if you're stressed or why you are stressed. Okay, so do you see the difference? The medical model goes, okay, I know you have a headache and I know Tylenol is going to get rid of it. So take some Tylenol and it'll get rid of it, right? But what happens if you constantly get headaches, and the reason why is because you really want to break up with your partner, right? And that's stressing you out and causing you to have headaches. So really the real problem is about breaking up with your partner more than just having the headache. Because if you did break up with your partner and you would feel better, then you're not going to have this headache. So you don't need the Tylenol. Coding that are the same as the International Classification of Diseases, also known as the ICD, and that is for insurance purposes. So the ICD is basically another type of a DSM, except for it's used in other countries and not in America as much. However, there is a call for people to start just shifting over to the ICD as well, so that it becomes a global thing. But it isn't there just yet because America, just like inches and the metric system and whatever, they like to be different, or let's say we like to be different, so we'll never have the same things everyone else does. All right, so there have been many revisions of the DSM over time. Like I said, we are currently on the 5th one. The first edition was done in 1952. The second edition was 1968. Provided a structure for naming and coding mental disorders that would be compatible with the coding system used in the ICD, just like we talked about in the previous slide. So there are things that are going to match up so that they can then be understood both in the ICD as well as the DSM. And of course, During this time period also, it would validate psychiatry. Psychiatry is basically being a doctor, but specifically giving you medication that comes with, let's say, certain types of mental health issues. Okay? So the DSM initially used psychoanalytic framework, and that is related to Freud, right? And then this different psychologies started to happen, which is behaviorism, existentialism, Gestalt, among others. And so then they started to also incorporate all those other ones in there as well. Social movements explain marginalized people of society. So also, when a specific population in the country are oppressed, are, let's say, discouraged, they're going to be upset, they're going to be sad, they're going to be dysfunctional. But it's not because of their own mental health, it's because of how society is treating them, right? So then we start to also put into that civil rights issues, the feminist movement. Social injustice could lead to emotional problems. If you're told you're not allowed to do things all the time and you feel like you can do it, but society goes, oh, well, women don't do that, then of course women are going to, scream and shout because they're like, no, we can do it. And so that means that we need to start to understand that some of the social expectations that we had need to now change. Psychiatry becomes our authority over psychopathology, so as we were talking about before, because psychiatrists usually have a medical degree. Psychotropic drugs become available, such as antipsychotics, antidepressants, mood stabilizer drugs. And institutions could release clients to outpatient care because if they take these medications in a regular basis, then manage their mental health, then they can actually live outside and it'll be totally fine, which is what we want, right? The least amount of restriction for each person. So, of course, then we're talking about psychiatrists, which are going to be different than psychologists, who usually do not necessarily prescribe medication, and counselors also do not normally provide medication. However, they all need to know what happens when a person takes a specific medication. What are the synapses? What is, the side effects? What are all those different things that actually could happen to that person? Now let's talk about the DSM-3, a shift to the medical model. In the 1980s, big changes started to happen. Like we said before, it was very medical model, right? Shifted to a biological model of mental disorders, which is still popular today. Moved from hospitals and institutions and into private practice, which is also known as outpatient care. Moved from severe disorders to less extreme, such as depression, anxiety, relationship problems. So although those are problems, most people can live with it, right? Counseling becomes more acceptable in society. Psychologists, social workers, marriage and family therapists, and counselors began using the DSM as well. So this is now not just psychiatrists who are using it, it's counselors, psychologists as well, and as well as other mental health experts. Psychiatry begins to lose its authority because now more and more people are using it, so it's not specialized to just psychiatry. Now let's talk about the DSM-4 and the DSM-4-TR, also known as text revision. So changes in societal norms and values happen. A major example is the removal of being gay from the DSM. Believe it or not, back in the less than 50 years ago, being gay was considered a mental disorder. And so they removed it, which means that because society started to accept people who are gay, then they're like, wait a minute, maybe being gay is not a mental disorder, right? So this is society actually influencing the DSM. Realization that many disorders are based not on objective science, but on political pressures, financial interests, and interprofessional turf battles. So what we start to realize is that the DSM and what is considered a mental illness for a very long time was actually more about society's view on things, right? So if society thinks that being gay is bad, then the book is going to say being gay is an illness, right? But then once we realize, oh, wait a minute, being gay is okay, that's fine, that's cool, then we need to remove it because it's actually more of a societal thing than it is about really a true mental health issue. Pharmaceutical industries play a huge part of research new disorders that then require their drugs for treatment. So now we also realize that pharmaceuticals, which are basically companies that make medication or pills, benefit from more diseases, more disabilities, more mental health issues. They're going to say, well, you have this, well, we have a drug for that. You have this, let's have a drug for that. So they're making a lot of money too. So then we need to also pay attention to, is this really helping a client, or is this really, an industry that's trying to make people be more sick so they can actually make more money from selling more drugs. The DSM-4 in 1994, the major criticism for it was the lack of cultural diversity. Okay, America is, fully diverse, right? And so we need to start to include that into all of these things because everyone has mental health issues, or anyone can have mental health issues, but some things are actually culturally specific, so you need to be able to understand that. And so the text revision, which is basically kind of like the edited version of the fixed up version of the DSM-4 called the DSM-4 TR, but it still wasn't fully addressed yet. And you have to think about this also. Talking about ethnicities and cultural diversity can be very hard, right? And the nuances and all those things. So it is going to be hard. But I will say, and I think many people applaud to the fact that they are trying and they're moving forward with it. And then that's a good thing. If you move forward, hopefully we'll get there someday, right? All right, now let's talk about the features of the DSM-5, which is the current one that we're using. It's divided into 3 sections and an appendix. So section 1 is introduction, guidelines for use, limitations of the diagnostic system for forensic purposes. So that means you can't just use it immediately for all, let's say, court-related stuff. It has to be very specific. You need to understand that. It also explains the groupings and orders of presentation. So similar disorders are together, present disorders within a developmental and lifespan framework, and enhanced compatibility with the ICD-10. So those are all the things that happen in section 1, right? It's kind of like a broad overview. Section 2 lists 21 categories of mental disorders arranged as chapters. A separate chapter addresses other conditions that are not considered to be mental disorders, but that may warrant clinical attention, and those are known as Z codes. Another thing is that they start to describe things in severity as mild, moderate, or severe. You'll also hear 3 specifiers such as impartial remission, in full remission, or prior history. And we're going to actually explain those in the next slide. All right, so impartial remission basically means that symptoms that once met the criteria for a mental disorder, but are now manifested in more limited ways. So you might have some of the characteristics that would qualify you, but not all of them now. So that's, well, impartial, right? Impartial remission, that makes sense, right? Parts of it are there. In full remission is symptoms no longer are evident, but that remain clinically relevant. So medication is working. So let's say that you have schizophrenia, right? And you take medication for it, and now you're pretty functioning, right? Successful, you have a job and all that other good stuff. So that would be considered in full remission, which means that you have it, but it's under control. So you kind of don't have it. Does that make sense? You still have it, but the symptoms are not there because of the medication. And then prior history is past disorders, no longer treated or in evidence, but still noteworthy, maybe only shows up under stress. So maybe you have anxiety, but it doesn't happen unless it's a special occasion where it's like a big deal. Like let's say the death of a loved one or something, then it goes all out, right? So then we need to pay attention to during those periods so we can help that person stabilize themselves. Disorders not specified, otherwise specified, also known as NOS in the DSM-4, is now called other specified OS. So NOS is now OS. In the client's signs and symptoms are consistent with the characteristics of a particular category of mental disorder, but do not fit into a specific diagnostic criteria set within that category. So what that is saying is, let's say that your client is coming in with anxiety, but it's not one of the ones that is in the 21 categories, right? So there's one where it's like, well, it's not in any of those, but it's still something in this one, right? So what that is saying is then you need to write OS on there so that it helps that person and helps you understand that we're still trying to either figure it out or something is going on that we need to explore further. And provisional basically means uncertain about a diagnostic or diagnosis due to incomplete or conflicting information. So let's say that when you're doing your intake and then you're doing counseling with this person, you notice that there's some weird stuff that's going on, like things that just don't match up. So then you would say it's a provisional diagnosis, which means we think this is it, but we're not sure because they're showing us evidence of specific things here and there that doesn't fit well with what we're hoping it would be or what we think it is. All right, section 3, alternative model for the diagnosis of personality disorders. So there's dysfunctional, deeply rooted personality traits, and stable over time. What we use is the Cultural Formulation Interview, or CFI. It's a semi-structured interview to determine if and how cultural factors might influence a client's perceptions. So it's kind of helping you understand that this person, because of their cultural differences, what is really going on. They got rid of the multi-axis system that was in the previous DSM-4. Axis 1 and 2 and 3 were combined. Axis 5, the GAF or the GAF, replaced with the WHO's disability assessment schedule. So they replaced certain things with other things that were deemed more dependable, more trustworthy. Describes diagnoses that are not yet part of the official nosology, which is basically the classification, but are being considered in the future. So, like autism is kind of newish, right? So what happens is there are other things that are popping up right now that we don't know if it's really a mental health issue just yet, but we're thinking about we need more research done before we can actually put it into the book. An example that I remember hearing about a while back was like addiction to video games or addiction to social media. Okay, in the thing it might not have it because we're like it's just so new because technology is so new, right? So they might put that. I don't know because I haven't looked at the DSM-5 in a while, but just as an example, as something that new, or whatever, I don't know, fake news, right? For some reason, some people just believe in it, even though they acknowledge that it is fake. It's weird. So that might be something that might be in that section. All right, adjustment disorders, people who are dealing with a significant stressor with impairment within 3 months of the stressor. So adjustment disorder basically means something is happening, which is why now this person's behaving the way they are. So it could be a negative life experience, such as a divorce, illness, being fired, or a positive life experience, such as marriage, birth of a child, or graduation. So the one that we're talking about here in this picture is, let's say, Hurricane Katrina that happened a couple years ago. So that's an adjustment because people are going to maybe behave differently because they just went through this traumatic event. So like we talked about before with the Hurricane Katrina example, people are dealing with property destruction, displacement, job loss, separation from loved ones, grieving the death of loved ones. So pain that they were experiencing makes sense with their losses. So if they're like acting out of the ordinary, it's because an out of an ordinary thing happened to them, right? A hurricane destroyed their entire lives. So they're going to be depressed, they're going to be anxious, they're going to be all these different things. So what we are trying to basically say when it comes to adjustment is kind of like temporary disabilities, okay? But after 6 months, then the diagnosis must change. So if it was for about 3 months or so, then, it is an adjustment thing. But if it keeps on going on, that means maybe they haven't learned how to cope with it or deal with it, or something else is going on. And so it's actually now longer, 6 months or more. Okay. The experiences of Hurricane Katrina is associated with PTSD, post-traumatic stress disorder. Adjustment disorders is seen as controversial due to the labeling of mental illness or disorders. So what that is saying right there is, like it shouldn't be a mental disorder, but it is because it's temporary, but then that might not necessarily be good because people might misunderstand that and think it's actually long-term or chronic or whatever it is. And it's not, it could potentially be a bad thing depending on how a person takes it or the people around them who have access to this information takes it. Now let's talk about the Z codes, which we talked about earlier. Note psychosocial or environmental circumstances that may be contributing to the client's distress, in conjunction with or as an added explanation of adjustment disorder or another trauma or stressor-related disorder or standalone. So what that is saying is basically that there are certain things that might come along with another thing, and that would be a Z code. Okay, so there might be a main thing, which is like, let's say, experiencing Hurricane Katrina where you lose everything, but then additional things might also pop up as well for some people, right? So that would be labeled as a Z code instead. Distress or dysfunction that is sufficient to require counseling, but does not rise to the level of a mental disorder. So they need help with it. They need to talk about it and stuff like that, but it's not necessarily a mental illness just yet. Okay. Z codes are not mental illness or disorders, but fall into a category of other conditions that may be a focus of clinical attention. So again, we don't want to dismiss it just because it's not a mental disorder because we want to know what's going to happen, but we also want to make sure that we prevent it if we can from it becoming a full, like, let's say long-term chronic type of thing. Now let's talk about developing a counseling treatment plan. In this class, we don't really focus a lot on the treatment plan. Part of it is because there's a whole class that you guys are taking in undergrad that deals with treatment planning, right? So I'm just going to review it here. And then when you take the other class, you will have literally the entire semester to focus on how to create a treatment plan. Okay, so it's simple, and there's complex versions of a treatment plan. The simple is a limited number of sessions of cognitive behavioral interventions for a simple phobia. Okay, so that's pretty easy, right? Let's say that I'm afraid of spiders. So it's going to be short term most likely, and it's not going to be very difficult or complicated. Complex would be long-term counseling and psychiatric care for a person with a major depressive disorder. So that person might need medication, might need to see a counselor all the time, and all this other stuff. So it's going to be complex. Okay. Considerations. Number one, does the client want long-term counseling with the hope of resolving deeper issues that contribute to their distress? Does the client want short-term intervention for symptom management? Two, what kind of counseling or other treatment is the client capable of engaging in? Client's current mental status, money, insurance coverage, access to social supports will affect that, right? Like if they want long term but they don't have any money, we need to figure out how to do this, right? We want to give them the care that they need, but if they don't have the money, unless you guys want to work for free, I don't want to work for free. So that's something that, obviously that we need to work out, right? We might have to refer them to a local nonprofit or something like that instead because, money is how the world goes, unfortunately. And then three, what kind of counseling are you able to offer the client based on variables such as your agency guidelines or your own level of experience and competence? So that means, let's say you are a addictions counseling center, right? And then this person wants to talk about career management. That's not necessarily your specialty. So you might have to then move them to a different place for that specific thing. However, let's say that they are working on their addictions and they want to think about working or going back to school to do work, then they might come to you specifically for the addictions part, but then they'll go talk to an employment specialist for the other part.